So next we have Dr. Urmil Chawla, professor in PGIMS Rohtak, on a topic which has gained notoriety during COVID, rhino orbital cerebral mucormycosis, lessons learned the hard way. So I think she's the right person because she has extensive experience and she handled many mucor cases. All cases from Haryana were being referred to her. So over to ma'am.
Thank you. Thank you, Dr. Ollie, for the kind introduction. And I will just take you back to those nightmarish days, which everybody of us went through. Some practically had to go through it, and some were through newspapers and news. We all were experiencing what was happening in our country. So I will just share with you my experiences. As you all know, India visualized a surge in mucormycosis cases since the novel coronavirus disease COVID-19 outbreak occurred, especially after the second wave in May 2021 onwards. Mucormycosis, just a general introduction, it's an angio-invasive fungal infection which can have multiple clinical presentation, which could be rhino-orbital, cerebral, pulmonary, GIT can be involved, and in few rare forms, cutaneous or cardiac involvement may be also there. It is more frequent in immunocompromised hosts with uncontrolled diabetes being the most important risk factor. This we were previously knowing also, and this was authenticated during this outbreak also. And coronavirus had triggered a new onset diabetes mellitus in many patients who were not diabetic before. So did India read mucormycosis right? As you all know, the country had reported more than 30,000 cases and over 2,000 deaths were by mucormycosis. And the real reason behind the spurt continues to be elusive. The disease has been wrongly dubbed as black fungus, which it is not. And the large number of missing links are still there. And it's still too early to jump to conclusions. The profile of ROCM in India, there were various states all over India it was involved, but a disproportionate increase in ROCM cases were seen in Gujarat, Madhya Pradesh, and Haryana was one of them where I was situated. And in Haryana also, there were few cities which were more involved. The reason for that we couldn't guess, but Gurgaon, Hisar, Faridabad, Rohtak were more involved. And also because being a tertiary center in Rohtak, we were getting more cases. Probably that was one of the reasons. And the number of mucor cases in Haryana started in 14th May when we had 27 cases were there. And the graph just got going and it was not ready to reduce. And by 14th June, we had 1,300 cases and 124 cases had died among those 1,300 cases. In Rohtak itself, where I was the nodal officer from ophthalmology department, 254 patients had reported COVID plus non-COVID. Out of them, this data pertains to 20th of June. And since it needed a multidisciplinary approach, various departments, nodal officers were posted, and I was one amongst them. And these we had the ENT department, maxillofacial, microbiology, radiology, anesthesia, every medicine, all team was made. So mucormycosis, and from our point of view, ophthalmic, the clinical spectrum, diagnostic approach, and the treatment overview I would give you. Age-wise, the range was from less than 20 to 80, more than 80 years patient, but maximum mean age was between, maximum patients were between 41 to 60 years, with the mean age being 55 years. And in gender, the males were involved more, and the reason found was that greater outdoor exposure and increased exposure to fungal spores amongst male was considered to be one of the common cause. The potential risk factors for COVID-19 associated ROCM, we all knew oxygen support was considered as one of the reason, and industrial oxygen that was being used those days extensively was also considered one of the reason for this spurt. 73% patients, however, showed no oxygen support. Still, they were having mucor. Most of these had diabetes mellitus, and majority received corticosteroids in some form, suggesting that contaminated oxygen may not be the driver of infection. So there was a debate every time whether it is responsible or not. Remdesivir and tocilizumab was also considered to play a role. Corticosteroids have been maligned, and the allegation is not totally ill-founded because irrational and injudicious use of corticosteroid was a possible cause of ROCM. There were other potential risk factors, diabetes mellitus being the main. Total number of diabetics that we saw were 190. Out of them, 121 were old diabetics, while 69 reported to have diabetes for the first time during the incidents. Then what was the COVID status of the patients? The RT-PCR was being done every time, and it was found that 47% patients were negative and 53% was positive. So it was not that only COVID patients were having mucor those days. The non-COVID patients were also coming up. And the duration after COVID, generally it was in 43% of cases, it was seen after more than 14 days of having COVID, while 56% showed within 14 days of having COVID. And few patients had delayed ROCM, like they had 3 months in the first wave they had COVID and they reported so late. So educating the patients and families with red flag signs is a good situation about they should be aware of the COVID symptoms. Laterality was not something very significant. However, unilateral involvement was seen in 71%, while bilateral involvement was seen in 4%. And there were 25% patients who did not have orbital involvement. Clinical features, those days we were getting all these tables from IJO and everywhere. This is by Dr. Honawar sir. All the symptoms, warning symptoms, nasal stuffiness, foul smell, epistaxis, nasal discharge, nasal mucosal erythema, eyelid edema, then regional pain, worsening headache, proptosis, all these were there. Other symptoms besides the common ones, there were headache, diplopia, toothache, loose teeth. These were seen in few of the patients. They were observed. And otherwise, you can see on this graph, maximum patients had proptosis, nasal discharge. Few came primarily with loss of vision at that time. Orbital and facial pain was very common. Orbital edema was the most. These are few patients I will just show you which presented to us initially with facial edema, nasal crusting, palatal erosion was seen. Ptosis was seen in many of them, unilateral to bilateral with partial to complete ophthalmoplegia. There were moderately aggressive cases with proptosis, chemosis, tight globe with ophthalmoplegia. Then there were patients coming with frozen globe with mild to moderate restriction was also there, and a total frozen globe was also there. Then periorbital discoloration to start with Ishar formation, and these were the maximum one, the N variable, I labeled them, who had maximum Ishar. These patients all reported to our institute and were treated. Besides the symptoms, the signs which commonly seen, vision PL negative was seen in 35 patients, 102 had 636 to PL positive, and similarly we had patients ranging till 612 also. Besides this, there was proptosis, diplopia, periorbital facial discoloration, Ishar formation was seen in less, out of them we would say 1% of cases. Nasal ulcer formation was there, ocular we've already discussed, facial palsy, altered sensorium was there. Retropulsion test, can you switch this video please on? Retropulsion test is considered to be one of the commonest tests which you can see. You just press, this is a normal eye, you just see there's softness when you press the globe, and this is this eye which is involved, you will feel a tightness, and this is a simple test done clinically bedside to check the resistance, and it just help us to grade into mild, moderate, severe. Retinal assessment seen showed patients having CRAO, optic disc pallor, CRVO and BRVO, and diabetic retinopathy. CRAO was considered to be one of the commonest cause that in patients who presented with PL negative vision. Going ahead with the investigation, RT-PCR was a must. Diagnostic, initially the patients were all reported into the ENT department, as that was the presenting finding in most of them. So a diagnostic nasal endoscopy with tissue biopsy, which and KOH staining, then these hyphae were seen. And once they were diagnosed on this, then these cultures were also sent, biopsy was done, all these cultures were done. Imaging was a must, and that time MRI was considered to be the gold standard, MRI contrast, and wherever feasible it was done. In few cases not feasible, we had to go with CT also, and CT PNS was also done. So this was the standard protocol being followed. And we could see patients having uninvolved orbit to extraocular muscle enlargement, and facial orbital involvement was also seen. In contrast MRI, there were black turbinate sign was the pathognomic sign we used to consider. Besides this, the presence of diffuse involvement reaching up to the orbital apex with a lack of enhancement, and cavernous sinus thrombosis, and in some cases bone destruction was also seen. So tenting of the globe was another finding which was pathognomic and showing that it is a severe disease. Maximum patient presented in stage 2, which was the PNS plus orbit. Sorry, stage 3, PNS plus initial stage was only of stage 1 nasal mucosa, stage 2 was PNS, and stage 3 maximum patient were PNS plus orbit, and then later on spread to CNS was also seen in many cases. Mean age, as I told you, 52.2. Regular monitoring of patients were done for diabetes, and aggressive surgical debridement was done. Another most commonly found comorbidity on all these patients was hypertension, beside chronic kidney disease, which was also observed. Transient dyselectrolemia was also seen, and few patients had old ischemic heart disease and were patients of post-organ transplant also. almost 66% cases as intraorbital extensions, and 16% patient developed CNS involvement, most commonly cavernous sinus thrombosis. So the orbital involvement was quite common. And to manage them, the patients were investigated as soon as they came, operated without delay. FES was done wherever needed. And amphotericin B also, that was another story. You all know what was the status at that time. Liposomal amphotericin B had almost disappeared from the market, and wherever it was there, it was at very high prices. So it was becoming very difficult. However, wherever possible, government had tried to provide it, and we had been giving it at a dose of 5 to 10 mg per kg per day with a cumulative dose of 3 gram. And posaconazole was added also in patients who had renal dysfunction. So clinically, whenever we suspected IV amphotericin, preferably liposomal, was given, confirmed diagnosis, then there were option of non-exenteration where only FES and retrobulbar ampho was another new thing that was done, TRAM, which was called, and in cases where exenteration was needed, it was done. So TRAM was this transcutaneous retrobulbar amphotericin B. It is an off-label application of that time. 1 ml of 3.5 mg amphotericin B with lidocaine was given, and at that time the knowledge was not known how to assess the situation and how many injections to be given. But with the clinical acumen and with experience of other people and with journals giving us idea, we were giving this drug. So it used to be given in the minor OT. Amphotericin was vial was mixed, 10 ml distilled water was mixed in 1 vial, and out of that 0.7 ml was taken, and 0.3 ml of distilled water was again added to it to bring it to the concentration of 3.5 mg, and then it was given in the quadrant where maximum disease was located on imaging or clinically where we felt. However, the infratemporal and the supromedial compartment were commonly used for this injection. So these are our 2 injections. The lignocaine was given first, followed by this. The affected eye, the injection was retrobulbarly given. I'll just go ahead because of shortage of time. This way TRAM was given, and TRAM also showed us improvement in vision in many of the cases. When to combine exenteration with sinus surgery, whenever it is early limited orbital disease, or we can avoid exenteration, but when it is an advanced orbital disease or rapidly progressive orbital disease, diffusely involved, and tenting of globe, as I said, is one of the common signs, we had to go for exenteration. Like in this case, orbital apex plus cavernous sinus involvement was there. QH was positive, MRI contrast was showing cavernous sinus attenuation, and so we had to plan an exenteration. Similarly, tenting of globe was an important sign, as I told you. Tenting of globe is defined as posterior globe angle of less than 130 degree. A normal angle of globe is 150 or more, but when the due to this disease occupying the posterior area, it causes tenting. It increases the optic nerve stretching due to increase in orbital tension due to inflammation and abscess, and that was an pathognomic sign again, and we did exenteration in all such cases. I'll go ahead with this. So this were the exenterated sockets after exenteration, and though in these also we had healthy orbital sockets, we found diseased orbital socket while doing exenteration. Lid sparing was done generally. Patients were kept on follow-up. Even after the exenteration, there were cases which were coming like this, so a long follow-up was needed for all them. Prosthetic rehabilitation was a must, and ocularists were involved in this, and we know spectacle mounted prostheses are there which are lightweight, user friendly and economical, and patients are still coming for follow-up, and they are still using these for cosmetic rehabilitation. So challenge was that there was a sudden influx of huge number of cases at that time, and it was an unprecedented mucus tsunami. There was deficiency of infrastructure, both man and machinery. There were paucity of beds, almost nil ammunition because amphotericin and posaconazole initial supply chain failure was there. Initially, intra-departmental communication was less. Everybody was in a panic till a mucor committee was formed, and then things streamlined, and public awareness due to wrong messages, and there was total chaos and state of confusion in the country. So take-home message was from my side was that prevention and early control of mucormycosis is the need of the hour, and we should detect it early rather than waiting for it. High morbidity and mortality with significant facial disfigurement in survivors has been seen. We have to remember now for our next future that moderation in steroid and use should be there. Strict control of diabetes. We should be aware of the red flag signs. Even now COVID is there so much, so we have to be careful.